Okay. Good. Okay, well, we will go ahead and get started here at 1:05. My name is Megan Smith, and I am the chair of the board, the Choice Board, and we will go ahead and do roll call. Mr. Jim Leach, I believe is not here. Mike Leach, I'm sorry, so sorry. Senator Ed Charbonneau. No. Sorry, I'm bad with names. Senator Mark Spencer, which is replacing Senator Lakeisha Jackson. Representative Ed Claire is here. Representative Carol Jackson. Not here. Ms. Joanne Burke. Hello, here. Tom Pearson.
Here.
Thank you, Tom. Is it Jonathan? But Giovanna Ward, I'm sorry. And Kelly Mitchell. Okay, and unfortunately, we do not have a quorum, so we will kind of table that for next meeting, as well as our chair elections. And then we will go straight into our presentation. Ms. Lisa will introduce our next presentation with community health workers.
Good afternoon. I'm Lisa Schneekloth. I'm the CEO of Socoa Aging and In-Home Solutions. And today we're going to have the honor of hearing my Director of Community Health Programs present on community health workers. And so I will turn it over to Mackenzie.
Thank you. Good afternoon. Good to see you again. You get to hear it twice today. So my name is Mackenzie Reed. Like Lisa mentioned, I'm our Director of Community Health Programs. So we're going to talk a little bit about our community health worker program today that we have had for the last few years. So I still didn't figure out who's doing the slides. Is it somebody in this room? No. Oh, great. Thank you. So if you're not familiar with community health workers, the kind of general definition is that they are frontline public health workers that help members of marginalized communities access the healthcare and community services that they need. Kind of the big magic around community health workers and what makes them different is that they are individuals that come from the same communities that they serve. So they speak the same languages, look like, have similar life circumstances to the folks that they serve. And this really helps to break down barriers between individuals and healthcare and other systems that are designed to serve them, that folks sometimes have barriers to for many valid reasons. So kind of the biggest piece, the biggest piece is that, you know, if you trust me and I trust Socoa, you could trust Socoa. That's kind of our kind of standard there. And so we have had community health workers since 2022. I was actually our first community health worker hired on at the time. And when we first started, we added them into our case management teams to be able to support individuals with the dual special needs plan Medicare for those alerts that we receive when they go to the hospital or nursing facility. And so we did just some care transition work with them for up to 90 days, strictly over the phone, and had some really great results that have led us to expand this program. So we did that for about the first 2 years and then expanded to include anybody with any insurance for care transitions, as well as what we call pre-Socoa clients. So these are individuals that may have chronic health conditions, may have social determinants of health risk factors, a recent fall, loss of a caregiver, and be able to outreach to them sooner to hopefully delay or prevent them from needing our other long-term services and supports, in addition to continuing to work with the folks that we already did. In 2024, June of 2024, we engaged in a partnership with Impact Care. They are the leading community health worker evidence-based program in the country. And so we have a partnership with them that really helped for us to just standardize the things that we were already doing. So now you can go to the next one. Thank you so much. So what our CHWs do, kind of what this looks like, as you see kind of the things on this slide, I would say that many of us that work in social service would probably say we do a combination of these things as well. The biggest piece is that these individuals will go and do things alongside individuals rather than just giving them a pick list or information and telling them to go do that work themselves. So we say that this is longer than options counseling, shorter than long-term case management, and doing things with the primary focus of connecting them to clinical and community care so that, again, they do some of these things sooner, more preventative care, are able to access these systems so that they don't end up needing us for long-term services as soon or at all is the goal. So a couple of examples, real examples of things that our community health workers have been able to do. We actually have a lot of folks that have been able to get permanent housing for individuals who were unhoused for a very long time or in unstable housing. So that's a huge win for us there. We had someone get an individual a new ID and insurance card, work through that process with them to be able to get a primary care appointment to work towards getting some durable medical equipment that they needed. I talked about this morning as well, but we do have a lot of individuals that will grocery shop with some of our clients for the purpose of being able to help them read labels or help them understand maybe a new diabetic diet, something like that. And so we have one particular client that was able to try hummus for the first time as a good snack that she had never had before. And I think she was in her 70s. And so was able to try this for the first time. And we talk a lot about the hummus lady because it was a very big deal for her to be able to try this and have something new and make her new diagnosis of diabetes a little less overwhelming. We also are really good about not necessarily knowing every resource that exists out there, but being able to creatively problem solve in the moment. And so we have one particular example where there was an individual with a recent cancer diagnosis who was using a wheelchair for mobility, lived on the 3rd floor of her building, and the elevator was broken. And her apartment complex was refusing to fix it. And so she could not get to all of her appointments that she needed to do, and RCHW advocated for a very long time to try to get it fixed and also to try to find alternate solutions for her. And while they were not at the time able to get the elevator fixed itself, they were able to get the local fire department to come out, help get her down, take her to appointment, and then bring her back up when she came back. So great problem solving there. We also help with just navigating all of the systems. So we help with a lot of SNAP applications, other programs that exist for individuals to help them navigate what can be a lengthy and overwhelming process if you don't do this every day. Okay, you can go to the next one. Perfect. So this is what our intervention looks like. This is along that impact model. And so we do a very robust first visit with them that includes both screening questions as well as getting to know you questions to help understand how we got to this point, not just what is needed now. And so the intervention itself lasts for up to 90 days and it's weekly in-person visits. So again, the goal is high intensity, short term to get folks stabilized to be able to remain home. And then we also are able to and have some partnerships with some local community organizations because we know we will get referrals internally from, clients that we are already serving with our other programs. But we want to also outreach and see who can we reach in the community where they are already congregating to see if we can get to them sooner and help give them awareness about this program. So we have some partnerships with our local YMCA, with a homeless shelter here in Indianapolis, with the public library, Gleaners Family Resource Center on the south side. So we have a lot of community locations where we have stationed CHWs or those individuals send us referrals to be able to reach these people that may never make it through our front door or the front door of a hospital. Okay. Perfect. So last year, we did an internal data analysis before we went to the US Aging Conference last year. And this is data representative of our first 2 years of the program. Again, this is really before we had everything standardized and really, I will say, knew what we were doing. So we anticipate that the data would be even greater now. But we did for that time see individuals with over a 30% increase that understood their medications. So we do this in a lot of different ways. We talk a lot about routines and making, the importance of taking medications, but we also have a partnership with the Purdue School of Pharmacy, where we partner with pharmacy students that work under the oversight of a pharmacist to be able to do medication reconciliation. So that one-time audit of medications to help them make sure they're taking the right medications for them. And then we also see an increase in overall mental health an increase in those that felt confident in continuing to receive home and community-based services, and a decrease in those without access to food. The biggest one I want to highlight for you is there at the bottom, which is the 64% decrease in overall hospital visits. So this is, again, we looked at the 3 months before intervention as well as the 3 months after intervention, and we're able to see the significant decrease. And as well as our internal review, we also did an official ROI calculation data analysis through the Purdue Center for Health Excellence, Quality and Innovation, CHECI. And they were able to find that for every 10 cents invested per client daily, which is the average cost of the program, there was an average absolute reduction of 0.775 emergency admissions and 0.306 inpatient admissions per client. So obviously, statistically significant progress with reductions. Yeah.
Well, I just want to underscore for the choice board, the 64% decrease in hospital visits,
Yes.
and that was validated through,
The Indiana Health Information Exchange. That is where we pulled all of that visit data from.
okay, and this other data was
Self-reported on a
So
free
that's
test.
very important. And this afternoon, somewhere in your report, I would like to hear for the choice board how the new legislation that was passed related to choice,
Yes.
how your programs such as this can benefit from that legislation.
Am I okay to answer that now to give a little bit of feedback now?
That's wonderful.
Okay. And I think that's certainly why we're excited to be here today. I know at the last meeting, Lisa was very excited to come share to like CHWs are the answer to what we're doing here. Because one of the biggest barriers to us being able to do this intervention is that majority of the reimbursement for a lot of folks is grant funded. And so being able to have a long-term sustainability option, we know that it is less expensive than a lot of other interventions, but we also know that it works. And so it is something that if we have the funding to support it, can help with things like decreased SDOH risk, Medicaid diversion, since we're keeping people home and out of those programs longer. So certainly a huge benefit to be able to do that, as well as stabilizing, again, individuals that may be, waiting on some longer services, like on a waiver wait list or something like that.
So specifically, I need
Yes.
more information on how choice can be used for this now.
Mhm.
It couldn't before, but it can now. So how does that work?
I don't know that as of today we can. It would have to be something, I believe, and somebody else back me up here too, of the biggest piece is that we would potentially be able to add this as an allowable service under choice, where it has not been an allowable service under Medicaid waiver, and the decoupling helps with that, for us to be able to create a specific service tied to community health work that can go on someone's choice service plan. I will address this when I. Great.
Okay, thank you.
Yeah. Any other questions that you all have for me?
I don't remember it. Did you talk about microphone here? Did you talk about how people are selected?
Oh, no, great question.
Okay.
So we get that information from the Indiana Health Information Exchange. So we outreach to the majority of our individuals that are case managed in some capacity, when they have gone to the hospital, because we can see those alerts and reach out and offer the program to them. We also get direct referrals from internal staff, and they have to meet 2 of our inclusion criteria. So a recent hospitalization, a recent fall, social determinants of health risk factor like food or housing, a loss of a primary caregiver. I feel like there's one that I'm missing. So we say they have to meet 2 or more simply because everybody that comes in our door meets at least 1. That's how they got to us.
How much visibility do you think you have as far as the population that could benefit? You just listed some of the ways that
Mhm.
people would come to you.
Yeah.
How much visibility do you have? How much more visibility do you need?
Yeah, short answer is not enough. Because it's a really a great program for individuals because at this time, for all the individuals that we serve, it's free to them based on our grants and other funding that we're able to do. So it also helps to fill a lot of the gaps that the other organizations that we partner with can't fill. So even if we just get, their top 5% of their acuity of clients, that still helps them a ton for those individuals that need someone to go do things with them. So we find a lot of our community visibility comes from those partners that we have. So we do have a health partner, all those other community partners that I listed, but certainly not everybody knows about it.
Well, you mentioned hospitals, and I'm looking at the 64% decrease in hospital visits. It would seem like hospitals would be beating down your door.
For sure.
Is that happening?
No.
Okay.
We do have a partnership with one of the local hospital systems here. The thing that we are running into transparently is that a lot of other hospitals are finding that they feel they can do this the same. They also have community health workers on staff. And so they don't always see the benefit in looping us in to do that work. So that's kind of where that comes in a little bit.
Wouldn't it be a savings for them for you to do it?
Yes, especially if they have the capacity to bill Medicare.
I asked your question, Dr.
yeah.
Burke.
It would be. It definitely would be. So if they have the ability to bill Medicare as well, they may actually profit from our intervention, depending on how their billing is set up and all of that. Because we are not really set up super well to bill for the new Medicare CHI code. But if a hospital system is already set up to do that billing, this could fulfill that requirement for them.
Can you name the hospital system that you are partnering with?
Okay, it's IU Methodist is who we are partnering with.
IU Methodist?
Yes,
Well.
for their senior programming. We had a previous contract with them that just switched to the community health worker intervention.
Well, I wonder if there's an opportunity to sit down with the hospitals through the hospital association, representing all of the hospitals, and maybe include I4A in that. I know this is a SACOA program, but there are certainly opportunities.
Absolutely.
I would think beyond SACOA.
Of
So
course.
I see Hannah Carlock back there. She needs another meeting. She's glaring at me.
But yes, that would be really, really wonderful, because I think that's the other part too that makes community health work really special, is that if you are hiring individuals that come from community, it can be tailored to all the different communities across the state. And we know that that is very best.
Exactly. I mean, I really see what you're doing as a model that could be replicated in other regions. Yeah.
Yeah.
Yeah. Thanks for your great work and your great presentation.
Thank you.
So that's what I'm seeing here. I mean, I am assuming if Choice is paying for this at this point in time, we'll have community health workers across our AAA now. Was that in the plan that was presented this morning? No. I'm sorry, I'm trying to see what we can put together with Medicare, Medicaid, hospitals, and AAA.
He didn't. SACOA addressed it in their area plan. I don't know that any other did, especially in relation to Choice, because the plan started before legislation was passed.
Yeah, that just happened, so. But I mean, what they're finding and what you have nationally with your other.
Correct.
Yeah.
Impact Care that we partner with. Yes.
Yeah, I mean, we do have evidence that this works. And we have some funding now through Choice. Thank you, Representative Claire, for pushing that through, and Hannah for all your work. And, but it just seems like we have an opportunity now. And I don't know what the plan is. We have the area plans that came out, an opportunity now, thanks to SACOA for getting this going in Indiana, but a good opportunity. And then, am I correct that the glitch with Medicare is that the AAAs aren't a traditional healthcare provider? Is that
Correct.
the issue we got going on there?
Yes. Medicare, the new CHI code requires provider referral and oversight. So
Yeah, and they want money for that. Okay, I got it.
yes. Well, and it's also just harder too, because if we have to route them through another primary care office, a lot of the work that we do builds trust with health systems. So if we have to start with the health system, that takes a lot of the people that are interested in the program away. We have to work up to that. So we need to be able to have a different model where we can get that referral to be able to say, yes, we know because we see them and we meet them, you know, at a homeless shelter at the Y. We know that they have social determinants of health needs. And us being able to do some sort of that evaluation and, you know, be able to have that support versus needing it to pass through a medical provider.
So we don't have any incentive on the hospital side, the health system side, to work with this. Do you understand what I'm saying?
I do. I mean, I think that's why it's important for there to be a meeting to talk about
For sure.
what the mutual benefit could be.
Absolutely.
Because I mean, this is in the AAA's wheelhouse, and I would think that hospitals would see opportunities for partnership. Obviously, IU Health does through Methodist, and I applaud that. And
Yes.
I hope that can be a model for others.
Yes, we're excited. That just started this month. So we're excited to see where that goes.
Yeah, I just think there needs to be more conversation about
Absolutely.
what's working and what's possible.
Absolutely. Yeah. And I think we really just have not had the chance to get in front of the right people yet. So I think at this point, we are certainly open to a conversation to do that for us, but also to help, you know, create that model like you shared for the entire network.
Yeah.
I mean, I would think primary care would be thrilled
Absolutely.
because, I mean, they don't know what to do with these folks. They have no idea. They have nowhere to send them. There's no social workers within the system.
Yep.
I mean, they may say, the hospital systems may say they have community health workers, but
Right.
come on, people.
Right.
There's not enough to help help these folks. So I just think this could work, especially if you're getting ER visits and you're getting nailed for
Yep.
too many people coming in for ER visits. So
Readmissions that affect
Yeah.
reimbursement,
Yeah.
negatively impact reimbursement.
That's certainly the fine line between we need some
Yeah.
people in the door, but only once.
Well, I'll say two things. One, this is another great example of AAA's identifying and meeting a need. I really appreciate what SACOA is doing. And second, I think, you know, we talked at our last choice board meeting about the AAA's working with the division, with Aaron and the rest of the team to measure, you know, these new activities
Yes.
under choice when we're talking about outreach and education leading to preventive intervention and Medicaid diversion. And I think this is another area where measurement matters a whole lot.
Yeah.
So I would hope when you do meet with the hospitals, you know, with Hannah and other representatives and stakeholders, that, you know, everybody could put their cards on the table, and, you know, you can put your 64% out there. And if there's a hospital system that thinks they can do better, then I think you would be the first to want to learn from them.
Of course.
And I would hope that they would be transparent enough to acknowledge that if they're not hitting 64% through whatever program they have internally, then there's an opportunity for partnership. So I think the numbers should drive it as much as anything, right?
I would hope so. Yes.
Yeah.
I would just like to say, talking about visibility of programs, I can't say there's great visibility in community health worker programs and health systems. Or we'd know about them.
Right. Well, the other thing too is we are very committed to making sure that we get it right as we do it. And so not making these case management light or navigators, which is what some health systems use their community health workers for, is being able to make sure that we are getting people from the community that can provide this, you know, person-centered, culturally competent support, is really where we see the magic happen. So. Well, thank you very much. You.
Okay, next up, we'll have Ms. Erin Wright with the Division of Aging to discuss the program updates.
Yes, good afternoon. I'll start just by addressing and following up on community health workers and where we are with kind of rolling that concept into choice. We last month had a meeting with the AAAs to go over House Enrolled Act 1391 and to start brainstorming additional services that we may want to add to choice. Measurement, outcomes, all different kinds of brainstorming related to 1391. You can go to the next slide. So from that meeting, we asked for volunteers to form a work group, and we have our first meeting next month. And the purpose of the work group is really to start in-depth conversations about all of the different aspects and conversation about community health workers. If we add it as a service to choice, what will that look like? Do we require service plans or not? What data do we need to collect and so on? So while we haven't officially added it as a service yet, we actually have set up their grant agreements and claiming processes to be able to include it once we get to that point, but we're still kind of in the planning stages for that. We have added it as an allowable service under Title 3B, under a service called health promotion non-evidence-based, because it doesn't meet ACL's evidence-based definition. I don't know that that's the right place for it under choice. So again, as we are working through the work groups, we'll have those conversations, but we're excited about the potential, and you're furrowing your brow a little bit.
Why does it not meet ACL's evidence-based definition?
It's a very long definition about having to have been through controlled studies and published articles, and there's a list, an
Yeah.
HHS list.
I bet there is.
Yes.
And one other question on this. I mean, I'm really excited about this. This makes a lot of sense to do this. And we touched on this just a little bit ago, so maybe we've already done it, but I mean, within government, Indiana government, I realize FSSA and health work in two different places that don't make any sense, really, but to me. As these plans are made, it sounds as if we need to somehow be sure that we get at least the hospital association involved, and I don't know if that's all that we need to get involved. We have to work together on this, or the AAAs are like outliers with healthcare instead of partners in healthcare. We brought it up a little bit ago. It's just an issue though. We got to get it on the table where they see it as a benefit.
Well, I gather Erin has a number of additional slides.
I do have some slides.
So
Yes.
I have a lot of questions, but I suspect you're going to answer some of my
Okay.
questions in your upcoming slides. So I'm going to hold my questions.
So Stephanie, next slide, please. Thank you. So I mentioned we met last month, just had an open conversation with representatives of all of the AAAs. We have made some updates to the grant language and our claiming workbook, just to put ourselves in a position to be able to expand our scope and respond to the changes to the program that will be unfolding as we implement Choice 3.0. But because of the timing of when grants need to move and all of that, we've already had to do that. And then, as I mentioned, we have our first work group meeting. I believe there's representation from 5 or 6 of the 15 AAAs. And at the first meeting, we're really going to focus on our work group goals and also the provider certification process. With the passage of 1391, there has been being referred to as decoupling of the choice program from Medicaid related to provider certification. So the list on the left are still those services that require that in order to be a choice provider, you also have to be a Medicaid or Medicaid waiver certified provider. The services on the right no longer require that Medicaid or Medicaid waiver certification. There are still requirements in Indiana code related to providers that will still apply to provider agencies, regardless of the decoupling. And this relates to things like background check and liability policies and HIPAA policies, really anything related to, trying to ensure that it's an, appropriate type of entity to be entering into a agreement or business with. So because we are really trying to break down any barriers to implement services with the passage of 1391. We've been working closely with our Office of General Counsel to try to design a process that is still in compliance, but the least restrictive to ensure that, the RSVP program can come to the table and help build the wheelchair ramp. So we are going to be kind of trying to finalize this process first. And I'm hoping when we have our conversation at the first work group meeting, we'll be in a good position to kind of move forward and be able to implement what the process is going to look like. Yes.
This was one of my questions, so I'll pause here if you don't mind.
Mhm.
Because you and I talked about this briefly.
Yes.
You say you're working with the Office of the General Counsel. Would it be possible to put together a package of boilerplate policies that would meet the threshold requirement of the OGC? You've already thought of that.
They're about done.
Okay, wonderful. So because I'm less concerned about, and I appreciate using the RSVP program as an example. I'm sure everybody in the room has an example of a nonprofit that could get involved. I'm less concerned about the nonprofits being able or willing to comply than I am contractors, for-profit contractors. So like a pest control company.
Mhm.
I want Lifespan to be able to have, 3 pest control companies to get bids from rather than one, because that's going to drive down the cost and stretch the dollars as we've discussed. But I'm concerned that, just using pest control as an example, pest control company may have no interest in developing its own HIPAA compliance policy, for example. So I think if a AAA could hand that to them in a packet and say, here are the 6 policies that you have to sign off on, or whatever the number is. And, we've got it all in a neat package for you. And, we're going to have somebody walk through this with you to make sure you understand that even if you don't read all the fine print, the bottom line is you have to protect the identity of, for example, of the clients. You can't put them on your billboard after you do a home modification, without appropriate permissions, that sort of thing. Does that make sense?
Yes, yes.
So-
And that was our thinking.
Okay.
And
So you're envisioning that sort of thing, a packet that would make, so they wouldn't have to develop their own policy. They could adopt a policy that has been developed and approved by the Office of General Counsel, and basically just a cookie cutter
yes,
process.
as an example of one. And then if the, AAAs would want to change anything, add anything for
Sure.
their own, because the, we're still trying to work out the logistics of where the provider approval actually happens in the process. If it's, the AAAs will make a recommendation to us, or if it comes first to us, we're still trying to figure out kind of those logistics and
You mean to the provider approval? So
because of how the language is written, we're trying to.
are you envisioning that each provider would have to be approved by the division?
The way that the language is written, if it's not, not one of the ones that we can just say, oh, they're a waiver provider, so we're good. For the ones that have been decoupled, there has to be a division approval. So we're trying to figure out, is there a way we can do broad approvals, delegate approval, we're just looking at all the options.
Yeah, I would think streamlining it as
Yeah.
much as possible and possibly delegating it if there's authority to do that.
Yes,
I mean,
that's the question.
I mean, the AAAs would need to be accountable, and I think they would be. I mean,
Right.
you know,
And we know that they're already entering into agreements for choice with them, and we don't want to further complicate the process or add additional administrative hurdles, because that is the opposite of what this is intended to do.
yeah, to put it very bluntly, we need to stretch the choice dollars as far as possible. And the more frictionless we can make things, the more competition we'll have, the more options the AAAs will have for service providers, and the better prices they'll get.
So this
sounds
will
like
be
you're-
our
you're-
first topic,
For the
deep
work.
dive next week with the work group.
Yeah, well, thank you for the work you've already done. You're well on your way, I can tell.
Thank you. I have a quick question with regarding the ramp program. Is this a program where these ramps are put up temporary? And then once the person either moves out of his home or whatever, those ramps are repurposed elsewhere?
Not generally.
Yeah, no.
Not generally.
I mean, they would be installed permanently on the property. A subsequent property owner may choose to remove the ramp, but a ramp is going to be installed on posts set in concrete and,
Okay.
attached.
Because I've seen the ones that are, you can.
Oh, you're talking about the metal ones?
repurpose the metal ones, exactly, and I'm just thinking, if those are the kind, then that is something that can be recycled. And as opposed to spending money and then it's one and done. That was all. Thank you.
And I know that through the process before a ramp of installation is approved, if the person indicates they're only going to be in the location for 2 months, then they probably are not appropriate to get a ramp funded through this program. But if they're planning to live there for an indefinite amount of time, then it would be appropriate.
I don't know about the metal ramps that are removable. Have you had any experience with those, Aaron?
I have not. I haven't been-
Lisa, has Sokoa or any other AAAs in the room? Jenny, I see Jenny back there. Has anybody had experience with the metal ramps that can be temporarily installed?
Yeah.
Done them in, as needed, as appropriate, sometimes in a rental situation. So it just depends on the structure.
The answer from Sokoa, for anybody listening online, is say that again. You've done them
We've done
like
them
for
in
rental.
Rental, sometimes rental properties, or if we don't know how long they're.
So Sokoa's done them on a limited basis based on the situation, rental being an example where there's an expectation that the person may not be there for longer than the term of the lease, for example. Yeah, thank you.
Okay, next slide. The other area I wanted to touch on today, primarily because I've been getting a lot of questions about it, is the language in 1391 that says the Office of the Secretary, in collaboration with I4A, may do a study and prepare a report containing recommendations for realigning and consolidating the planning and service areas. And the map is up there. We currently have 16. We are in the process because there are federal and state requirements related to if we are going to realign these service areas, change them in any way. Actually, there are these processes that we have to follow. Next slide. So we are trying to map all of that out to fully understand like the process, what the requirements are, that if we are to do a study, what we would need to make sure is included. We'll obviously gather feedback from stakeholders, but we're first trying to just dig through those federal and state requirements before we move forward with anything, just to kind of understand what is needed. And with the federal requirements, we essentially will receive approval for any changes, if any changes end up being recommended through our state plan on aging. And our next state plan on aging is due next spring. So with that timing, there's not the likelihood that anything would be able to be implemented in the beginning in federal fiscal year 27. So it likely we would be looking at later.
As you dig into that, Aaron, it might be interesting for the next choice board meeting to have a flow chart or something to educate all of us with respect to process and requirements, timelines, you know, things like that. If it's not too much trouble, I'd
Yeah, no,
like to
that's
see
what
that
we're
illustrated.
working on, trying to keep hitting this, trying to see how the different pieces fit together, because there's
Yeah.
a state requirement that we hold a public hearing in every impacted county, and no changes can be made until 1 year from the date of that public hearing. So it can say there's a total redraw of them, that's 92 public hearings. So we're trying to figure out that
That's in statute.
it's in statute.
Yeah. I think that was in one of my bills.
Yeah, thank you.
Thank you.
I remember that. Well, I think at the time, the concern was and remains that there be adequate time for
Right.
communities to have input and buy-in.
Right.
And I think that still holds.
I agree.
You know, I don't know if a year is the magic number, but I remember we came up, I can't remember how many years ago that was, but I do remember that. And as part of the illustration, I'd be, you know, very interested to know if there's anything you anticipate needing to happen legislatively in the 26th session to facilitate anything that you may want to work on or partner on with the AAAs.
So we'll keep you posted on that, but I know there's a lot of questions about it now, so. So keep you posted on just our implementation of Choice 3.0. Just next slide, wanted to quickly highlight where we are with the waiting list. We currently, I guess as of yesterday, have 3,189 individuals on the wait list. That's about a 30% increase from this time last year. I know it's kind of hard to read. We have, for the most part, couple areas have experienced decreases in their wait lists. Some have remained relatively steady, and then some have grown. And the really high numbers for the percentage increase, it's for those that went from 1 to 10. So that's why it's such a huge percentage.
Well, and for like Area 14 had 0, so you can't it says 0%. I guess it couldn't be calculated because it went.
Yeah, I think it just.
Yeah, so.
So as we're working on the Choice 3.0 and we're talking about the prioritization of funding and how the funds are directed, I think part of that conversation will be related to how do we prioritize consistently across the state folks that are on the waiting list and coming off the waiting list, understanding that each of the AAAs manage their own budgets and have different providers in their areas and whatnot, but that's going to be part of the conversation. Yes.
Yes, I'm looking at your total numbers, but they don't represent which districts. Do you have something that represents which districts?
The AAAs down the side are the 16 different areas. So, and I think in your folder, there's a map.
You mean legislative districts?
Oh, legislative
Yeah.
districts. Okay,
She's-
yeah.
Representative Jackson's talking about legislative districts, and
Okay.
there's no way to do that because the AAAs are based on clusters of counties, and our districts obviously take in,
Smaller districts.
portions of counties. So without drilling down by address of the individual, I don't think there'd be any way to do that.
And before I pass it over to Vanessa or Robbie to talk about Adult Protective Services, if you can go to the next slide, I just wanted to provide an update on the pathways and health and wellness waiting lists. Again, sharing the link for where this information is available online. We are, as of July 1st, started a new waiver year. Next slide. And this is just pulled from the website, so it'll be easier to see if you are curious and go to the website. We anticipate there's 16,127 total slots for the health and wellness waiver. And as of end of last month, there were 5,470 individuals on the H&W waiting list. With the rollover to the new waiver year, we anticipate that 890 waiting list invitations or slots for position on the health and wellness waiver will be issued. The first round of new waiting list invitations are going to go out next week on the 23rd. And then in subsequent months, it will be the third Wednesday of the month.
So how many do you anticipate having on the waiting list? It's as of June, last month, it was 5,470, and you're going to invite 890. So does that
But we're
mean
also getting new,
new slots?
Yeah.
well, those are the new slots, but new people are being added to the wait list as well. So,
Oh, right,
Yeah.
right. But you're, okay, yeah, I mean,
It's like with June 30th, so we're already 17 days into the next month.
yeah, but where do you expect to be in terms of wait lists after the 890 anticipated are invited?
I will have to check. I'm not sure unless, from the LFAR, no, okay. I will have to ask and put that in my follow-up email. Because I, off the top of my head, don't know the rate that people are being added. So I will
But-
follow up on that.
How many, let's see, I'm trying to get my head around this. So are the slots that had been spoken for but weren't being used reset as of July 1?
Right.
So how many, to use that term, how many slots reset?
We anticipate having 890.
So the 890 represents
Includes-
all of the
Yeah,
slots that became available again.
yes.
Okay. So once we invite the 890 people, give or take, we're out of slots again.
Yes, though there is that process where if an individual does not respond to the waiting list invitation within 180 days, the slots essentially recycle. That's probably not the right word. So
Well,
there will be new invitations after the 890.
so how many, I don't mean to put you on the spot, Aaron, but off the top of your head, can you give a ballpark figure of how many outstanding invitations there are that may not be spoken for after 100? I know it's a rolling figure, so any idea how many are out there that may be available, may become available?
So I know that in the months prior, as we were just ramping up with the recycling of the slots due to individuals not responding within 180 days. It was about 200, I think, a month. I think as more people are becoming more aware of that, the numbers started to go down. I don't know going forward what it'll be, but also.
But best case in round numbers, based on historical numbers, would be about 200 a month becoming available. And you're saying that the absorption has probably increased somewhat, which means there will be fewer than 200 a month becoming available in all likelihood.
That, yes,
So if we look at a 6-month period, I mean, best case scenario would be what, 1,200 slots, but it sounds like maybe more like 1,000 or fewer. So I'm sorry, go ahead.
I was gonna say, with that 200 number, I may be getting it the H and W
Yeah.
combined with the pathways too.
Okay, well,
So I don't know that.
that would make it even worse. But not your fault at all. I appreciate the your willingness to talk about it and to be so transparent. The bottom line is, it looks like we're still going to be hovering around 5,000 on the waiting list. And that is likely to grow incrementally over the next year.
I think
Because,
that's a fair,
right, because we have,
assessment.
how many do we have applying for health and wellness, entering the waiting list now on a monthly basis?
I don't have that number off the top
Okay.
of my head, but I will check on that.
But it's more than the best case scenario of 200 slots becoming available.
I can't say for certain,
Okay.
but I would think that is an accurate.
Again, not trying to pin you down, but I mean, what I'm getting at is just from a big picture standpoint, I think, we're looking at a waiting list around 5,000, with time on waiting list inevitably lengthening for lots of individuals.
Because the second to the right column is the date of the last original level of care invited. So the June invitations were from June of last year.
Yeah. Well, I don't want to get bogged down on it. I just wanted to understand the numbers a little better. And even though we're making some incremental progress, we obviously are going to have a significant waiting list over the next year.
And then pathways on the next slide. We have 39,842 slots, about 8,000 were on the waiting list as of the end of last month. We anticipate rolling out invitations over the next couple of months for 1,320 individuals. And I will also, for pathways, see if I can get a figure for the number that are added each month as well. Just, I know somebody has it, I just don't have it. Yes.
Do you, could you, give us your guesstimate as to why the waiting list for pathways is so large? I know the last time, we spoke on it, it was some difficulty navigating the online, platform. I'm wondering, is that some of the reason why, people aren't able to navigate the online, application in the process, or is it just that they aren't completing the application, or what?
We don't have enough slots.
Yeah, yeah.
We just don't have.
Yeah, I mean, the bottom line is we don't have enough slots. I don't mean to step on your
No.
toes, Aaron, but and there have been, technical issues and
Yeah,
other issues, but at the end of the day, we simply don't have enough slots. It's the situation with pathways is analogous to what we just discussed with health and wellness. We're going to invite another 1,300 people, give or take. And then we'll have invitations that people don't take advantage of from the last 6-month period that will be periodically becoming available again to invite new people. But that's going to be an incremental number that's probably Aaron's gonna have to check whether that 200 was health and wellness and pathways or just health and wellness, but
I think it was combined. I don't know for
combined.
sure.
But regardless, I mean, we're talking about just an incremental availability of slots every month. So we're in the the new fiscal year with a waiting list that is likely to remain 6,000 plus for the foreseeable future.
And I do want to clarify that this waiting list is for the Pathways waiver, not the Pathways Medicaid program, managed care program. So this is just related to the waiver. If you're over 60 with Medicaid, you'll be enrolled in the Pathways managed care, but the waiver has the waiting list.
Yeah, this is just the waiver.
Just the
list.
waiver. Yeah,
Right.
there's no waiting list for
Right.
Pathways.
This is what until July 1 of last year would have been the A portion of the old A&D waiver. Right.
Yes,
Yeah.
yes.
So let me ask a couple of important questions. One, I'm concerned about the pressure that these waiting lists for health and wellness and pathways may put on the choice program. Has there been any discussion of that? And what are your thoughts?
So for individuals that are active with the choice service plan who are determined to be now appropriate for either the pathways or the health and wellness waiver, they're in one of the priority groups for the waiting list. And the number is there and it's too small. I can't see it even with my glasses, but that's how many people,
It's the transition from choice.
yeah, 344.
Yeah, 344 at the bottom.
Last year, that's how many individuals were in that priority category to transition from choice to the waiver. So they were essentially able to
Right.
transition. So I think we haven't seen anything in the data yet that really speaks to this. We will be, by the end of September, sharing the state fiscal 25 choice annual report, and this will be discussed in there from that perspective. I'm sure that will speak to the impact more at this point than,
Yeah.
than
Well,
I could.
when waiver and choice were both housed within the AAAs, we often saw situations where we'd run out of waiver slots and they would put somebody on choice to bridge that gap. But now those are obviously administered separately, and we've made a very intentional statement about Medicaid diversion,
Right.
prioritizing choice for Medicaid diversion. So, I hate for anyone not to receive services, but I don't want to see us go backward and put pressure on choice because we don't have enough slots in the two waiver programs.
So when that's on our planning list with the AAAs, as we're talking about
Okay.
through the work group, talking about prioritization of use of funding, where does this fit in? If we're trying to prioritize Medicaid diversion and reaching people earlier through prevention with the limited choice dollars, it makes sense to prioritize bridging the gap till the waiver slot becomes available, or focusing more on building up the community health worker type
Yeah.
program. So those are all, I think, the conversations that we'll have as a group, because
Well,
we have our perspective at the state, but we're not the ones out in the field doing the work. So we really want to make sure it's a collaborative, thoughtful process and try to work towards some consistency, so you can't get, if you're on the wait list in one area, then
Yeah.
you'll get on choice, but in another area, they're not doing that because that's not
right.
necessarily fair.
Well, I think it's important that we continue to move the choice discussion toward prevention. So I hope that weighs heavily in that discussion. I see heads nodding out there.
Yeah.
But what you just mentioned, Aaron, consistency, I think when you all get together and talk, one thing we've always struggled with is, you alluded to this, that each AAA administers their choice waiting list differently. And I think we need, I don't know that we need to standardize the way they administer it. I think the AAAs should have as much flexibility as possible to do what's right for their community. But I do think there would be some value now in standardizing the reporting of those numbers so that when we see the list of AAAs and how many people are on the waiting list in each region, we understand apples to apples comparison. Does that make sense?
It does, yes.
And then the other thing I wanted to ask you to talk about before you hand over the mic is the funding situation, because we have the 5% reduction from the legislature, the additional 5% of reversion, right? And then the CAMS.
Yeah, so
replacement.
choice, and I'll confirm with our controller, but that extra 5% for the reversion or set aside was not directed to choice.
Okay, good.
Um,
That's
so it was the 5% overall cut with the choice allocation. The 12.5 million that's transferred right off the top to Medicaid did not change, which ended up making the 5% reduction a little higher. I can't remember the number, 6 or 7%. And then we are in the process of replacing our care management system, and we had anticipating receiving a certain level of federal match to support the transition, which ended up not being allowable by CMS, which then led to us having to use more choice funding than we had originally planned for, because essentially now we're operating CAMS until it sunsets in early 2026, but we're also having to build the new system. So the federal match that we thought was going to make it negligible did not happen. So
I know this is a sensitive time. Thank you for all of the
Mhm.
explanation. So it sounds like with the CAMS obligation and the math around the waiver match and everything, that's great news about the reversion. So that puts us more in probably like a, what, 8%?
I think it was still
9%?
about 12.
Is it still 12?
Yes.
Because of the math around the waiver match?
Mhm.
Okay,
That and the, yes.
okay.
I'm hoping that as we kind of get more into the development process and understand what the costs are and try to find opportunities to match different aspects of the process, that we'll be able to identify some additional funds and amend this year's contracts. For next year, we I won't say with 100% certainty, but very much should be able to increase the allocation for, because the grants will be for 2 years. They'll have a state fiscal year 26 and then 27 in the same grant. So we anticipate being able to amend for 27 because we won't be running 2 systems anymore. But at this point, we don't know what that dollar amount's going to be, so we couldn't put it in.
Well, what I was going to say is sensitive is, I know we're at the very end of ARPA, but there are still some little pots of ARPA money that I keep hearing about that, aren't getting spent for the thing that they were going to be spent for. And I mean, is there any possibility at this late date that we could go scrape together, a few $100,000 of unused ARPA money and use that for this software, because the software touches, all the program areas. And I know, I mean, everybody in FSSA has done incredible work over the last several years with ARPA. It's been an unwieldy, sometimes nonsensical, my word, not yours, not nonsensical process, or just a very frustrating process. But I think, isn't it September when the money has to finally be spent?
So the HCBS ARPA, the billions, I don't remember
Yeah.
what the dollar amount, that closed out in March.
Yeah.
So that's gone. We do have some Older Americans Act ARPA.
Mhm.
And I think there's some, I don't know if it's Elder Justice or APS, somehow something in that space, ARPA, that expires at the end of September. At the state, we don't have any of those that we would be able to use for this. And because it's, at least for the Older Americans Act ARPA, since it's distributed through the funding formula to the AAAs, it's tied up there.
So there's no money left no ARPA money left in state coffers that could be reallocated at this point. Darn.
We tried.
I'm sure you did.
Okay,
Well, you're doing great work.
thank you.
Thanks for everything. And for anybody who's listening, we had a ceremonial bill signing on 1391 with Governor Braun, and Dr. Burke came down, and of course Hannah Carlock was there, Lisa from Socoa, Jenny from Area 9 was there. But Aaron, thank you for coming down and being a part of that. There was a lot of energy around that, and I think it got great media coverage. And thanks to all the participation and support, I think it raised a lot of awareness.
Thank you. What'd you say? 64?
Aaron, before you leave. Finally clarified in my head what my question was earlier regarding community health workers. And I think that that's really important for some saving, as you were talking about with prevention earlier. But here's my question. What is Indiana's definition of a community health worker? I don't think we have any kind of, there's no professional designation. When we talk about navigators in hospitals, I mean, when we're talking with healthcare and we're here in social services, we don't have a professional designation for a community health worker. I'm not saying we should, we shouldn't, whatever, but I'm just suggesting that as this goes into a further discussion, because what does a navigator do in a health system versus a community health worker? I think we need a definition. That's what was going on in my mind when I didn't make any sense a little bit ago. I
Okay,
was trying to figure out what I was asking, but
okay.
we need
wrote it down.
something to put out there.
Yeah. Maybe one at the state level at this piece, but the Indiana Community Health Worker Association has designated certifying bodies that they work with. And that's part of, I know that was established at least in part from Medicaid funding. So there are definitions that exist that can certainly be adopted for that.
Yeah, so as you know, you listed out the between the Medicaid certified list of what was there and the non-Medicaid, this and that, and your own designation for certifying what's what out of the division. It just seemed to me like we need a definition that works in the state of Indiana for this function.
Added it to my list.
Thank you.
Thank you.
Okay. Now we will go with our Adult Protective Service update.
Hi, good afternoon. My name is Pravi Najar. I'm the new APS director. Vanessa is still heavily involved in APS, and I'm just working through the transition with her. So we're gonna give you guys an update on how APS is doing and how the transition is going. Next slide. So what is changing in APS? So it is no longer going to be operated by the county prosecutors. So our new vendor, who is going to be basically running the APS program is PCG Indiana, so Public Consulting Group of Indiana. And then APS investigations will be managed by 5 regional teams as opposed to our other units. And it would be coordinated under a statewide model as opposed to the previous model where the units kind of were working in silos to do their own thing. So we are working on standardizing the APS model so there's more consistency across the board. And we're using all our standardization tools. We have a lot of procedures put in place. All of our trainings are consistent across the board with everyone that we're hiring, and even incumbent staff that has moved towards the new program, they are also getting trained. So we are on the same page right off the bat. There will be a new statewide email address dedicated to incidents reports, so that's also what's changing. So what is not changing? It's going to be the mandated reporting. All Hoosiers are still required to report any kind of adult maltreatment. Report content, it should include the demographics, maltreatment details, and optionally reporter information. Client rights are not changing. Adults retain the right to decline APS service under court ordered. And then the state APS contact email is still the same. So if anyone has any questions, concerns about what's going on, you guys can still reach us at aps@fssa.in.gov. So that has not changed as of right now. So who is PCG? So PCG is a nationally recognized human services consulting firm. They've actually worked with Indiana on quite a few projects. They operate in all 50 states. And their expertise lies mostly in Medicaid, child welfare, aging services, and disability systems. And they has provided APS oversight, policy research, and a lot of data to really support the new model going in. So in Indiana, PCG also administers the First Steps Early Intervention Program. So they also work with that. So a lot of what PCG is doing is very data focused, which we're really excited about. Next slide, please. So a little bit of how to report. So this is still going to be live. This is live right now. We transitioned on July 1st. So you have the phone number here. You have the online reporting portal. So this portal is the same portal that is used if you would call 211. They're also using the same portal, so you can access it yourself and do your online reporting if you need to. And then incident reports are going to go to that email address, which is a little bit long, but I'm going to leave it up on the screen for a little bit so people have a chance to write it down. We'll also share this slideshow, so if you don't catch it, it's you will be provided the slideshow with the incident report email address. So it's INAPS provider incident reports at pcgus.com. Next slide, please. So how intake investigations are going to work. So all reports are going to be screened using a statewide risk tool. Cases are prioritized according to risk, and investigators conduct face-to-face visits, risk assessments, and coordinate voluntary services. So we're going to be using for priority model the ABCs. So going into a little bit of the details of what that is. So the A would be the 24-hour period, B is a 4-day period, and then C is going to be a 20-day period. So this is going to be the priority levels that are going to be used. As far as how things are going to be moving forward, we do have 3 case specialists that are going to be screening all the incidents that are coming through, and they are working with all of Indiana, not just a certain region. So that way they are screening everything through for all of Indiana. And then, like I said, we did divide up the state into 5 regions. So every region has a supervisor, and then those regions have their regional investigators. And then there is also an operations manager from PCG that kind of overlooks at the whole program as a whole for Indiana. So transition commitments from us, ensure uninterrupted access to APS reporting and investigations, minimize disruptions to open and ongoing APS cases, and PCG will be working closely with FSSA to ensure readiness and accountability. So we've been meeting with PCG almost 2 to 3 times a week since the beginning of this transition, and we have these meetings ongoing for the next couple of weeks, I would say, going into this transition, just to make sure that we aren't missing anything, nothing is kind of, dropping out, or something's getting not transitioned well, the cases are being worked on. So we're meeting very regularly, not just with PCG, but the whole team as a whole that's working, just to make sure that we're not missing anything. So this is a regional map. So it's been divided up, and this regional map was conducted through a lot of data that PCG pulled from us. It was data in regards to caseload per county, but also on demographic information and population. And these are just some resources that are provided in the next couple of slides for the Indiana law, federal law, national best practices guidance, and then the APS contract with PCG. And that's the reporting information, the hotline again, then our email addresses, the state APS website, and then the RISE model information that is published. And more information on the APS website and NAPSA as well.
Two quick questions. The email address is ridiculously long. Can we not,
Up without.
can you come up with a shorter one? Seriously.
Very, that incident reports here, this is where we go, so that's why it's.
Yeah, I just worry about, I saw several opportunities in that address for a misspelling or a mishearing to lead to a lack of report, like reports in that address, if I remember it correctly, is plural.
Yeah.
If someone doesn't make reports plural, but rather makes it singular, then it's maybe gonna go out into the ether and never reach its destination. So
We can definitely.
I would just urge you,
Yeah. Talk to BCG about that.
I mean, I think it's more important to, in whatever information is making the email address available, describe, what the email address is for, in the written description, and then make the email address really user-friendly, really short and user-friendly. The other question is, you talked about individuals declining APS services. Excuse me. So when an individual declines, and this isn't necessarily relevant to the transition, although I think the transition is a good time to talk about it. What happens procedurally to ascertain, to the best of your ability that the individual has competency or capacity, to decline and isn't under duress?
I will let Vanessa answer.
You want to come to the mic so folks who are watching online can hear, and I'll ask the question again. The question is, when an individual declines APS services, what process is in place to ensure as best as possible that first of all, the individual has competency or capacity to decline, and second, that they aren't under duress and that that's not the reason for their declining services?
You are touching on one of the trickiest things that we deal with.
I know.
In Dog Protective Services.
That's why I asked the question.
Yeah.
Well, because it gets to the heart of the matter. I mean, when you have an individual who needs APS services and they're under duress to decline the services, I mean, that's the heart of it, right?
Yeah, I mean, I'll be honest, there's only so much we can do if someone chooses to decline and we do not have evidence that they are not capable of making that choice themselves. Client rights, right? I will not bore you with things you probably already know about our rights to making those kinds of decisions, to self-determination. But it's definitely a thing and it's something we have to be very cautious of. So of course it makes a difference if we've already got evidence, if there's already a guardian in place, or if there's already, something from a doctor or something from a court stating that this person is not able to make their own decisions. That obviously makes our lives easier, because then we can say, well, we can already see that that's something we need to address.
Right.
It is significantly more difficult if we don't already have that evidence. And if we can't convince somebody to talk to a doctor and to potentially get that evidence. So we do try to do that. We do our best to engage. And I mean, this is really where engagement skills come in key for this
Right.
role.
And
which
that does
was-
relate to the transition.
Yeah,
Yeah.
yes, which is why it's such an important part of our training and our discussions and our SOPs even.
Yeah.
Yeah, because that engagement piece is absolutely critical. Because it is weird. You're walking into a situation where you kind of have to convince somebody sometimes that they shouldn't be making those decisions for themselves, or that I know that you don't recognize this right now, but you're in a situation of abuse, neglect, or exploitation.
Right.
And sometimes that takes multiple visits, multiple phone calls. Getting in touch with people's supports is really big there, especially informal, but if there are formal, that as well, of course, but typically there aren't, right? Normally in those situations, you're just hoping to find a family member or a friend who has the capacity to see what's going on and to understand and to help support in that conversation. But you're right, at the end of the day, if we don't have evidence and somebody is convinced that they are fine, there's not much we can do.
Well, and my question was in no way a criticism of what you're doing or, any part of the transition. But I guess a follow-up question would be, if an individual declines, is there a process in place to follow up with that individual periodically?
Not necessarily. We can keep the case open for a certain amount of time, and we will, to just kind of check in. But obviously we can't keep it open forever. That doesn't help. That can make things worse. So what we can do there is take really good notes and just be aware, so that if this person ends up back in the system again, we still have that historical information to help us moving forward.
Good. Well, thank you for that explanation. Appreciate it.
Thank you. And now we will have an update with the level of care assessment representative. Welcome back.
Amazing. All right. Okay, so hi, I'm back. My name is Vanessa Conrad. If we've not met before, I am the Service Enrichment and Advancement Director for the Division of Aging. So that means that I manage the APS program, as well as PASSAR portions of LCAR, and community engagement and all of our outreach efforts. So what I'm primarily going to be focused on today is talking about our PASSAR overview, what that means for LCAR, because PASSAR is now a part of LCAR, of course. What has changed, what remains the same, what the roles look like, and then hopefully we've got a couple of minutes for Q&A. We'll see how that goes. I'll try to get through this quickly for you. Okay, so how PASSAR relates to LCAR. The whole purpose of LCAR is to combine our functional eligibility processes. So we were already using the same level of care assessment for both PASSAR as well as our HCBS waivers. And we wanted to see a more consistent process out of these and more consistent results out of those assessments. So the purpose of LCAR was to bring those things together. This gives you the basic purpose of PASSAR, which, if you're not aware, is pre-admission screening and resident review. It's a federal process. It's part of the Omnibus Act. It's been around since the early 80s. And the purpose of it is to prevent institutionalization, to make sure that people are getting the right service in the right place at the right time, which of course is what we're also trying to do with our waivers. Now, the LCAR piece, LCAR stands for Level of Care Assessment Representative. Maximus is our LCAR vendor. So we combine those functional eligibility processes to make them one streamlined process, and to try to create an increase in that consistency over those assessments.
Some of the big things we've seen are role changes with who does the level of care assessment. So Maximus has now taken over the level of care assessments that were being done by the AAAs. Hospitals are still continuing the level of care assessments for nursing facility admissions for people who are coming from a hospital. They used to do what we call the short form. Now they are required to do the long form because the short form is no more. But that's the only big change for them. And then for nursing facilities, the big change is that they no longer complete level of care for initial admissions. They will still do them for people who need continued care after admitting to a nursing facility. And come 2026, those will also be done by Maximus. For our level of care changes, like the specific assessments, again, there's no longer a short form, so it's just the long form now, so that we have that full holistic assessment. And we also introduced 2 new forms because we've been using the IHC, but the IHC is really designed for adults. And we've been using it for our pediatric population and just being real flexible in some things to make sure that we're addressing their needs properly. So now we've introduced these tools, which are newer tools from the NRI for peds and early years, so we can catch those ages of 0 to 17 in a more appropriate way. And this gives you just some resources if you want to do a deeper dive into what's going on with LCAR. So that first link will give you a detail on those rule changes. The second link has all of the webinars that have been done by Maximus and all of the stakeholder communication that has ever gone out. That's all at that website. And then the last website is just our general LCAR website that gives you information on what LCAR is and what they do. Okay, I think that's the fastest presentation I've ever given. So do we have any questions?
Yes.
Yes.
You know, for a while, we have talked about how to help our population in Indiana understand how to access programs, because we have had a problem in Indiana. And it had been noted that we weren't strong in access. Do we have a place on the FSSA website that describes the process people need to follow in order to access these programs? I'm talking about a simple, something that is simple and easy to understand, because it's hard to sit in these, I've been sitting in these meetings for years and I don't understand it. I don't work in the bottom of it, and I know our administration said they didn't want the Pathways program advertised and marketed, but I have a problem with people paying taxes and not understanding tax-supported programs. I think people have a right to understand them. I think that's a fair ask. And I'm asking the question again. I mean, it just is, and I know we need to do something about this in Indiana. This is ridiculous.
So this is gonna sound like a bit of a bias because I was one of the people that reviewed and approved the website. But I do feel like both the LCAR website that is on the DDARS page, as well as the LCAR website that is on the Maximus page, and they do refer to each other on their pages. I do feel like those are like lay it out pretty well, what you need to do, where you need to go, who you need to call. But I'm also, in all honesty, not the person who has to make that phone call, right? I'm not the one and I don't know that we have had the opportunity yet to field that with people who actually have to use the websites. So I think that is one of the things that we are paying attention to as we move forward. And when we hear people talk about difficulty with that access, making sure that we are updating the websites in a way that improves their understanding of what it is that they should be doing or could be doing. Yeah, absolutely.
Just wanted to add, in recognizing how complicated the system of access is, that's probably putting it mildly. In the current state fiscal year 26 ADRC contracts, because that contract looks different now because of the transition to the LCAR, we have funding in there to support what we're calling No Wrong Door long-term services and supports navigation, just essentially to help people wherever they are in the process get where they need to go. So kind of, I don't want to say hand holding, but sort of just helping and recognizing that it is really complicated and there's a lot of layers and players, and just trying to support the support that the AAAs are, kind of naturally set up to provide. So, I mean, I'm sure that we could fund it at 3 times the level if we had the funding, and that probably may not be enough, but we're trying, so. just wanted to add
Well,
that.
the CASOA survey, the Hamilton County data indicated that 74%, and this is the most affluent county in Indiana, 74% of people 65 and over didn't know what services were available. Now we got to do better than that in 2025. And I've gone to some other states and looked at how to apply the things. And there's some states that are putting it out much easier than others. And I'm just doing an ask here. I think we need to work on this in Indiana. Really?
Yeah.
Thank you.
Yeah, absolutely.
Pardon?
People are falling through the cracks.
Yep.
Yeah.
Yeah, and the population's not getting smaller over the years, so. Yeah. All right, any other questions? Okay. All right, I highly encourage you to take a look at those resources when you get a chance, and if you do have any further questions, you know how to get a hold of us.
Thank you.
Thank you.
Okay, and moving on to updates with the FSSA Pathways Division on Aging. I'm just gonna go do that.
Super fast because we're already over and I want Hannah to have an opportunity. The only update that I will give right now is I wanted to make everyone aware that on August 6th in the auditorium right out here in the atrium, FSSA is doing its second quarterly financial review where all of the divisions of FSSA will provide a fiscal update to the public. It is in the auditorium, as I said, and it's also being streamed on YouTube. And the Division of Aging's update is scheduled for 12:30 p.m. And I'll send this out with the link in the slides and the
That's all
follow-up.
August 6th.
Yeah.
Wednesday, the 6th.
What time?
The Division of Aging is at 12:30, right after lunch. There is on our website a schedule of when Medicaid goes, DDARS, OECOSL, all of the other ones. So really encourage if you're able to attend to come out and show support for the different divisions. We are also having our first annual Celebrating Innovations in Aging conference in October. Some more information to come on that.
You have dates on that?
October 28th.
28th, and what's it called?
Celebrating Innovations in Aging.
Will the secretary have walk-on music on the 6th?
I cannot promise that.
Okay.
Okay, next up, we have Miss Hannah for our I4A update.
I'll make it quick. So I'm Hannah Carlock. I'm with RJL Solutions, and I'm currently the interim CEO of the Indiana Association of Area Agencies on Aging. And Representative Clear alluded to this earlier. He worked really, really hard to get Governor Braun down to Southern Indiana for a ceremonial bill signing of House Enrolled Act 1391, which was our choice bill, and was successful with that. So thank you for your efforts there, and for all of the choice board members and Commission on Aging board members that were able to attend. We also had FSSA there as well, AAA leadership. And then there were roughly like 60 people there, including members of the media, legislators, AARP, and then some folks that do utilize the choice programs. That was wonderful that the governor got to interact with them. And there were roughly 6 different media outlets that did stories on the bill and the choice program and AAAs. And so that was really good coverage for just the choice program itself. And then House Enrolled Act 1297, that's the yellow dot bill. Every AAA is going to be hosting legislators and first responders and AARP to discuss ways for us to partner to really educate around the yellow dot bill. So if you aren't familiar with that, FSSA is working on putting together packets, and they'll be disseminating those to AAAs and BMV locations for anybody to pick up the packet. You put the sticker on the rear window of your vehicle, and that alerts first responders to know that you have important medical information in your glove box. And so a lot of first responders had no idea about this. And so it's great to educate them on it, but also that they can build those relationships with people in their community, including legislators and AAAs. So we have done 2 of those meetings, and we will be visiting all AAAs for continued education. Last thing I'll update on is there was this big, beautiful bill that was recently signed into law at the federal level, which is cutting nearly $1 trillion in Medicaid over 10 years. Now that's the United States, not, $1 trillion to Indiana, but we will be seeing new work requirements with Medicaid and a lot of other re-eligibility tests, more frequent tests there, and just some other restrictions, some more skin in the game from the state. And so if we want to continue having services, they'll be funded at different levels from the federal government than they currently are now, which will require more funding from the state. So we will probably see that trickle down to programs like Choice and other Medicaid waiver slots and stuff, just because legislators will have tough decisions when it comes to funding.
That'll be fun.
No pressure, Representative Blair and Representative Jackson, because I know you guys have to make tough decisions, but that's going to be coming down over the next decade. So on a high note, we'll take any questions.
Comment and a question. Thank you for helping make the bill signing so successful. It would not have been nearly as successful without your help and the support of all of the AAA leadership that attended, along with so many other key stakeholders. I mentioned Aaron Wright earlier. Other folks from FSSA were there.
Dr. Burke.
Dr. Burke was there, yes, of course. We had representation from both Choice Board and the Commission on Aging. Yeah, but you were a big part of it. And I think we had, what, about 6 AAA CEOs there? Yeah. And one of the best parts, I think Dr. Burke will certainly echo this, along with others who were there, is that we had 3 choice clients. Yeah. And we really tried to spotlight them because that's what it was and is all about. So I just wanted to acknowledge you, Hannah, and I4A for, we wouldn't have had a bill without you and I4A and your leadership and advocacy, and the bill signing wouldn't have been what it was without you. So thank you. Question, yellow dot, you mentioned BMV and a physical packet at the branches, right?
Yes.
Are they doing anything online to, because so many people are renewing
Everything online.
online. So is there going to be checkbox or something that pops up? You're smiling, so I think you already have this covered.
The thing about these meetings is we are fully vetting the legislation after it passed. So we're finding out just different questions that
Yeah.
people have, and that has been a question, especially as people's health change. There are multiple members in a family, so do you get multiple different medical information per packet. So how many slips are in there? And so I know that the Division of Aging has a lot on their plate to figure that all out. But that has been a question about providing a link. And so Erin, do you have any insight on that yet, or should we stay tuned for the update? Yeah, so we'll have the division update once those packets are ready and what all is included. But that has been a question. Is there going to be a link available, as well as if somebody messes up, can they just go and print something off to update their packets?
Will they
Yeah.
email to them as well?
No, so they would have to go
You
to
have to go there.
a
Okay.
AAA or a BMV, but yes, you are correct. A lot of people are doing things virtually, and so was the future of that look like? So I do also foresee us probably having to have a cleanup bill to update some things.
Well, you
section.
know, BMV updates their website and back end periodically the same way all state agencies do. So I'm just suggesting that I don't know if anybody's factored this in, but at some point there ought to be an actual question, you know, are you aware of this? Do you want this? You know, check the
Yes.
box, whatever,
So
it
the
could be factored into
The BMV did
upgrade.
not want responsibility
Yeah.
for this. And so that's why the Division of Aging is shouldering all of this, even though it's open to all Hoosiers, which is another whole funding aspect because they don't have all the funding for the entire state for that. So we're working on trying to find funding partners. And then there's been questions from first responders. Well, could there be even an indicator on the driver's license or other things that the BMV could be doing with all of this? And so I think that that's where we're going to have to possibly have another bill around this regarding the BMV, because the BMV is saying, well, that's going to cost more and more dollars.
But that's what I was getting at, is that if it could be built into one of their regular update or upgrade cycles, you know, when they're doing other things to the website and to the back end, then the costs should be pretty minimal. Where does the yellow dot go?
Like a
On-
sticker?
Yes, it's a sticker, and it'll be placed on the driver's side rear window.
Yeah. I wonder if it could ever be on the license plate.
That's what I'm wondering, because I don't want it on my car, but it's a great idea.
Yeah.
Well, I'm just thinking if someone who wants to take advantage of that, again, putting this on the BMV, I guess, but I mean, you know, their little sticker that has the year on it, you know, I don't think it would cost too much to make some stickers with a yellow dot on them.
It's true.
Agree.
Yeah, and then it would be in the same location, you know, on the license plate, so that first responders would see that.
Before they even
Or if
pull
they-
you off.
Yeah, exactly.
It's like in your face.
Yeah.
Yeah.
Or if they sell their car,
Yes,
they can't get the sticker off.
yes.
Yeah.
Then
that's
do they
true.
get another sticker?
Yeah, and there's multiple people have multiple vehicles in a family, so how many there's been a lot of questions
We
come
have
out
all
about
questions
this.
for you.
Also just, Erin and I had this conversation earlier, but, is this a way to target people as well? If they see a yellow dot, like, oh, let's break into your car, see what kind of medications you're on, and then follow you home. So what are the reporting measures for the negative aspects of
Yeah.
this? So all these meetings, and we've only had 2, and there's, you know, 15 AAAs that we're going to be visiting, has brought to light a lot of different things. So stay tuned.
It's very excellent idea. But definitely a lot to go with it.
Yes.
I'm so glad you're in this role.
Okay.
Thank you, Hannah.
Thank you.
Okay, I think we'll wrap it up. Do we adjourn? Yes.
Okay, thank you.
Thank you.
Thank you, Ed and Representative Jackson, both of you for coming today.
Pleasure. Good to be with you as always. Yeah. So great to have you down in New Albany. I hope you enjoyed your visit.
Did,
Yeah,
got a lot going on down there.
you've got a lot of good stuff going on, yeah.
You do have a lot going on down there. It's quite a campus. They're calling it a campus now, right? For the, is that what they're calling it? Her life, I always get life resources.
Lifespan?
Lifespan resources.
Well, I mean, it's in the YMCA building there, and they have other facilities nearby. Yeah, there's
Okay,
a lot going on.
Yeah, it's great.
I feel like we're getting some really good attention on some of these issues.
Yeah.
Well,
I really,
with you and I here to ask questions, you know. Right?
Well, that's what it's about a lot and kind of stir it up a little. And I've got some things going with some presentations I'm going through. From the Commission on Aging. and Trying to get more going on. and working. Got something going on in Orange County and doing the presentation.
Cool. Reach out anytime if you want to make me aware of anything.
All right. Thank you.
Good to see you.
Good to see you. Good to see you, Representative Jackson.
Carol,
good to see you, Dr. Burke. Good to see you as always.
doing okay?
Yes, I am so sorry. I wanted to go so bad. But.
No worries. It's a long haul.